going to talk about office measurements. Out of office measurement will be taken up in another lecture. Evaluation of hypertensive patients should confirm the diagnosis of hypertension, assess cardiovascular risk, organ damages, associated conditions, and detect causes of secondary hypertension. You do this by medical history, physical examination, and useful investigations, as well as diagnostic tests. In the assessment of the hypertensive patient, patient's medical history as taught in classical textbooks of medical practice should be adopted. Family history is very important, very crucial, should be given emphasis to investigate familial predisposition to hypertension, which is very, very common, as well as other cardiovascular diseases. Physical examination includes careful office blood pressure measurement using a validated blood pressure monitor with a cuff size appropriate to the arm dimensions, as we are going to elucidate later on. The conditions should be in a relaxed atmosphere according to the general expert recommendation. Blood pressure ideally should have 2 readings of blood pressure, and of course we recommend ambulatory, which is not covered in this lecture, to rule out white coat hypertension. Self-measurement devices are encouraged so that people can check outside office as well, and even at night when necessary. The measuring devices available over the years are shown. The aneroid was the earliest one, and it's not commonly used these days. Then the mercury one, used for almost more than a century now. The electronic equipment came in not too long ago, but they've become very useful and are commonly recommended in many countries. Like I mentioned earlier, for more than a century, the mercury sphygmomanometer was the gold standard. Its use is now discouraged because of potential harm linked to mercury toxicity, which have been noted in some countries. For the automated devices, a good number of them are now available, as shown. You have the arm ones, most of them are arm. You also have the wrist one. The arm recorders are preferred because the wrist one tends to give slightly lower blood pressure than what the patient actually has. The use of this electronic apparatus in developing countries meets problems with regard to the availability, the affordability, so that the mercury device remains largely used in these countries at the moment. The decision to use automated blood pressure machine will rely on their cost, the cost of batteries, the cost of annual maintenance, as well as durability of the device. The approach, of course, after taking history from the patient, is to spend some time on the physical examination and assess the blood pressure with an adapted cuff to the arm size of the patient. Patient's body weight greater than 95 kg or arm circumference greater than 35 centimeters. Standard cuffs generate spuriously higher blood values in these people. The recommended cuff size are shown on this slide. For people with small arm circumference, 18 to 26 centimeters, you use 9 by 18 centimeters of cuff size. For adult sizes, the first one, 27 to 33 centimeters arm size, you use cuff size 12 by 23 centimeters. For large adults, 35 to 44 centimeters of arm size, you use 15 by 31. And for adults those who are quite large, for the thigh, when you need to use the thigh instead of the arm for some reason, the thigh circumference of 45 to 52 centimeters, you have to use a cuff size of 16 by 36. Blood pressure should be measured at the upper arms, preferably after the patient has relaxed about 5 minutes in the sitting position. At least 2 measurements should be taken 1 to 2 minutes apart, with additional measurements required if the first two are quite different. Measure blood pressure at both arms the first time. If the systolic blood pressure differs by more than 10 millimeters of mercury between arms, the arm with higher blood pressure should be used. Blood pressure should also be measured 1 to 3 minutes after standing in elderly subjects, diabetic patients, and in other conditions where orthostatic hypotension may be frequent. Orthostatic hypotension is a reduction of systolic blood pressure greater than or equal to 20 millimeters of mercury, or diastolic blood pressure greater than or equal to 10 millimeters of mercury within 3 minutes of standing upright. Let's talk about errors. Errors in measuring blood pressure. It could be from the instrument, monitor dysfunction, leakage, stethoscope defects, cuff size not adapted to the patient's arm, or it could be observer-induced, not the instrument. Difficulty in distinguishing Korokov or correctly read the values. It could be inattentiveness on part of the doctor or the patient. It could be inconsistency in diastolic pressure using phase 4 instead of phase 5. It could be also subconscious bias, digit preference. There, preconceived notions of what the normal blood pressures are. All these are very frequent in the mercury type, and that is why it is not commonly used in most countries currently. The errors that could be linked to the patient, the position is important. We usually encourage patients to be sitting, but in some cases, the patient may not even be able to sit, may have to be supine, or also we may need to check standing, like we mentioned earlier, to detect orthostatic hypotension. Arm position is important in relation to the heart level. It should be kept, the arm should be resting on the table at the level of the heart. Biological factors, anxiety, meals, checking blood pressure immediately after a heavy meal might affect that. Tobacco, alcohol, variation in temperatures, exercise, and patient in pain can affect the blood pressure, as well as the medical environment can also affect the patient. So let the patient acclimatize to the environment before you start checking the blood pressure. We are going to stop here, but out of office blood pressure, like I mentioned, is usually recommended. The reason is to rule out white coat hypertension. Some people with normal blood pressure, because of the fear, anxiety on visiting a doctor in his office, most doctors will wear their white coats, clinical jackets we call them, and that sometimes frightens the patient. That's why it's called white coat. So out of office recording or ambulatory blood pressure has become in vogue and is only used. An entire lecture is dedicated to that in this series. So ambulatory blood pressure measurement, like I said, is usually done within 24 hours. Another advantage is that you are able to check the blood pressure at night. You need to detect, usually a normal blood pressure dip, you get lowest values at night while the patient is sleeping, while the individual is sleeping. This is called dip, night dip. The blood pressure dips, becomes lower than the daytime one. Absence of this dipping has prognostic implication on the patient's cardiovascular conditions. So it's very, very important. It should be recommended for patients where the blood pressure is difficult to control, patients where there's consistent difference between office blood pressure and any values the patient has measured out of office. So this is very, very important for ambulatory blood pressure. And the ambulatory blood pressure measurement is reasonably good because it's 24 hours, daytime and nighttime. It is less good for shorter periods. It's better to do it for 24 hours. And then you look at this and then take note of dipping or non-dipping. To show the importance of both office and out of office, you can see the difference here on this slide. The blood pressure, office blood pressure of greater than or equal to 140 millimeters of mercury and or diastolic of equal to greater than 90, which is definition of blood pressure. For these values, for ambulatory, lower values are usually used, as you can see here. Daytime, greater than or equal to 135 millimeters of mercury systolic. For diastolic, greater than or equal to 85 millimeters. Higher than this, the person is said to be hypertensive. For nighttime, use 120 greater than or equal to millimeters of mercury for systolic, and for diastolic, greater than or equal to 70. For 24 hours average, use for ambulatory, use greater than or equal to 130 millimeters and or greater than or equal to 80. Home blood pressure measurement, which is not ambulatory, which means you may not even check in the night, use greater than or equal to 135 millimeters mercury and or diastolic of equal to greater than 85 millimeters of mercury. In addition to the visual plots, average daytime, nighttime, and 24 hours blood pressure are the most commonly used variables in clinical practice. The definitions of daytime and nighttime are based on the times of getting up and going to bed from the diary, the short fixed time periods in which rising and retiring periods are all recorded. Day from 10 a.m. to 8 p.m. or day from 9 a.m. to 9 p.m. and also night usually recorded fully. Night to day blood pressure ratio, the ratio of nighttime to daytime averages are shown here. Absence of dipping when it's equal to or less than 1. Then the mild dipping proper when there's a difference between the daytime and the nighttime. Extreme dipping is also recorded. The prognostic significance of ambulatory blood pressure measurement. The correlation of ambulatory blood pressure and organ damage is much closer than that of office blood pressure. Ambulatory blood pressure appears to be a better predictor of clinical outcomes, such as fatal and non-fatal coronary events and stroke, than office blood pressure in the general population, in young and old people, in men and women, in untreated and treated hypertensive patients, in those with high risk and cardiovascular or renal disease. Studies that accounted for daytime and nighttime blood pressure in the same statistical model found that nighttime blood pressure is a stronger predictor of morbidity and mortality than daytime blood pressure. With regard to the dipping pattern, the incidence of cardiovascular events is higher in patients with a lesser or no drop in nighttime blood pressure than in those with greater drop. 24-hour ambulatory blood pressure monitoring devices are not as readily available in the majority of developing countries compared to developed countries. The procedure, though beneficial, is thus not possible for most hypertensive subjects in these settings. Availability is gradually improving. The diagnostic evaluation of high blood pressure machines, methodical aspect. The technique usually involves self-measurement of blood pressure, but in some patients, the support of a trained health provider or family member may be needed. Blood pressure should be measured daily on at least 3 to 4 days, and preferably on 7 consecutive days. Blood pressure is measured twice in the morning and twice in the evening, after 5 minutes rest in the sitting position and 1 to 2 minutes between measurements. Home blood pressure is the average of these readings with the exclusion of the first monitoring day. The diagnostic evaluation of home blood pressure, relation with organ damage and prognostic significance. Home blood pressure is more closely related to hypertensive-induced organ damage, such as left ventricular hypertrophy, than office blood pressure. Meta-analysis of the few prospective studies in the general population in primary care and the hypertensive patients indicate that the prediction of cardiovascular morbidity and mortality is significantly better with home blood pressure than with office blood pressure. Studies in which both ambulatory blood pressure monitoring and the high blood pressure machines were performed showed that home blood pressure is at least as well correlated with organ damage than ambulatory blood pressure, and that the prognostic significance of home blood pressure is similar to that of ambulatory blood pressure after adjustment for age and gender. The definitions according to office blood pressure and that of blood pressure, daytime ambulatory or home blood pressure measurement. The daytime ambulatory blood pressure or home blood pressure in millimeters of mercury, and the office one. Office systolic blood pressure should be less than 140 millimeters of mercury, and diastolic blood pressure should be less than 90. And for daytime ambulatory blood pressure, that is out of office, the systolic blood pressure should be less than 135 millimeters of mercury. The diastolic blood pressure should be less than 85 millimeters. And then for true normotensives, that is for the values I've just mentioned. For those with masked hypertension, the systolic blood pressure should be equal to less than 135, or the diastolic blood pressure of less than or equal to 85 millimeters of mercury. The clinical indications for out-of-office blood pressure. Conventional office blood pressure measurement currently remains the gold standard for screening, diagnosis, and management of hypertension. Out-of-office blood pressure is an important adjunct to office blood pressure. Although there are important differences between ambulatory blood pressure machine and high blood pressure machines, home blood pressure measuring machines, the choice between the two methods will depend on indication, availability, ease, cost of use, and, if appropriate, patient preference. It is advisable to confirm borderline or abnormal findings on high blood pressure machines with ambulatory blood pressure machines, which is currently considered the reference for out-of-office blood pressure, with the additional advantage of provisional night-time blood pressure values. The clinical indications for